We're going to get started shortly. I think, Tanya, is everything ready on your end?
Yes.
Okay, perfect. So hi, everyone. Good morning again. We're excited to host today's presentation about monkeypox. So today with us, we have Dr. Heidi Torres. She is an attending physician for infectious diseases and an assistant hospital epidemiologist at New York Presbyterian, Weill Cornell Medical Center. So in this presentation, she's going to talk a bit more about what monkeypox is and how it can be prevented and shed some light on this illness that I think is a little misunderstood still to this day. So whenever you're ready, Dr. Torres, feel free to take the floor and introduce yourself as well. Thank you.
Sounds good. Hi, everyone. I'm going to go ahead and start sharing my slides. Okay. And so today's topic is going to be both about monkeypox and I'm going to touch a little bit about polio. Let me go to start slideshow. Okay. All right. Everyone should be seeing the main PowerPoint title screen. Let me know if that's not the case. So
I think I see your presenter mode.
Oh, my presenter mode? Yeah, let me swap
Slide
them over. Let me do this instead. Share screen. Let's go here. Okay. How about now? Does that look like one clear presentation slide?
Is your screen shared? I don't think you're sharing it with us.
How about now?
Oh, perfect. Yes.
Good. Okay. 2 years into the pandemic, finally can learn how to use Zoom. Okay. All right, everybody. So I'm going to be talking today about both polio and monkeypox. So these are kind of two infections. One of them has been around since this new outbreak since the summer, and another one is kind of on the I guess on the side of resurgence. So we'll talk about that a little bit. I'm going to be giving this talk with a cough drop just because I'm still recovering from losing my voice recently. So I apologize if I'm not too loud or if I'm muffled. Please just let me know and I'll try to speak a little clearer or speak up. So I'm one of the infectious disease attendings at the New York Presbyterian Cornell Hospital, and I also work in infection control and epidemiology. So these are things that, you know, have come across my desk as both a physician and someone who observes new cases and tries to figure out where they came from. So the way I designed this talk is question and answer based. So I've tried to focus on a lot of the questions I've gotten over the last few months and give you guys clear answers. This presentation is catered for the community, so I'm not going to dive into, you know, a lot of specific nitty-gritty details that we usually talk to, you know, healthcare providers about. This is more the basics and what's important to know and how you guys can go about understanding these processes, these new infections. So let's start off with what is monkeypox. So monkeypox has been around for many, many decades. It is a DNA virus, so it's a viral infection. It was first discovered in the late 50s in Europe in research monkeys. So it can be transmitted by multiple different types of animals, and it's suspected to be able to be transmitted by all kinds of mammals. So like I said, it was found first in monkeys, but we know rodents can carry it, and we know, of course, now that humans are also carriers as of many decades. The true reservoir is unknown, so we don't know exactly the original animal that hosted this infection or if that's, you know, still true today. But we know, like I said, that lots of other mammals can transmit it. So the main thing monkeypox causes is these skin lesions and rash. It can cause a couple other things, which we'll talk about. But the rash and the skin lesions are what make it very characteristic and what make it stand out. So it's endemic to certain parts of Africa. So when I say endemic, that means that it's originally was found in certain countries in Africa. Now it's spread in this current outbreak to countries that are non-endemic or do not natively have this infection. And that's what makes this, this outbreak of this year new or unique. So there's two different types of groups of this infection, or clades, and that is determined by how they are genetically different from each other. And they also have different presentations. So there's two main clades. There's the West African clade and there's the Central African clade. So the Central African clade is the one that we believe has, I'm sorry, the Western African clade has a lower mortality. It's found on the west coast of certain parts of Africa. And traditionally, this isn't really what we're seeing right now, but traditionally it causes a death rate about 1%. So one death in every 100 people infected. Now the Central African clade, it's higher than that, and it goes up to 10% mortality, and it's about one death in every 10 people that are infected. Now, most infections, most diseases, they do affect the extremes of age. So they affect the very young and the very elderly. And of course, those people who have weakened immune systems. So someone with HIV, for example, someone who's on chemotherapy, et cetera, et cetera. So what we're seeing right now across many, many countries, including the US, is a spread of the Western clade, African clade. So this has a much lower mortality. But I think it's important to remember when we talk about the mortality of this disease in places like Africa, we have to think about what's their access to care, what treatments do they have, how early can they make a diagnosis. In developed countries, we have more resources, more information. So, you know, we haven't seen anything that represents this many people dying from the disease, which is good. So to give you a brief history of this infection, so like I mentioned, it was first discovered in monkeys and research monkeys in the late 50s. The first human case was reported in 1970, before it was not known that it could infect humans. And there was the first human-to-human outbreak in the Democratic Republic of Congo. So this was in 1996 to 97. We saw the first human-to-human outbreak. Again, at that point, it was new that it could spread between humans. In 2003, there was a very unfortunate but curious situation where about 47 people in the US contracted human monkeypox because they had prairie dogs as pets, and these prairie dogs had actually been housed in Africa close to other rodents that were suspected to be infected with monkeypox. So the prairie dogs were infected. They were transported to the US. They're owned as pets. Their owners, many of them became ill, became infected, and they all survived and did well. But it was linked directly from Africa to these infected prairie dogs. And since then, since that 2003 outbreak, which was the first time this infection was reported outside of Africa, so that was a very big deal. There have been a few cases here and there, but they've always been linked to travel. Someone who came from an area that was, has that infection endemically. Up until 2022, which is where we are now. So what's happening now? So as of around May of this year, multiple countries across the world, started in Europe first and then spread to many other countries, including the US, started to have this rare infection that was not known to be commonly transmitted outside of Africa, except these minor exceptions that we mentioned. And it was no longer linked directly to one case from Africa, one case from an infected person. It was now being reported in patients who had no travel history, who had no known contacts. So it was very new. Now, it spread very rapidly through the MSM community. For those of you who aren't familiar, MSM is basically any man who has intercourse or intimacy with another man. Some of them identify as gay, some of them do not, but that's the terminology we use, the MSM community. So it spread to this community very rapidly. And there were festivals of the MSM community that also kind of propelled that spread. And there was much faster human-to-human transmission that was expected and that has ever been seen before. So a lot of new things were happening. You have this infection that's popping up in countries that had never popped up, with no linkage to Africa, in this MSM community, spreading very, very quickly. So as of now, there's been more than 80,000 global cases. Around 110 countries have reported cases. In the US, there's been close to 30,000 cases, with a good amount of those in New York. I believe the highest states are California and New York. And New York City has a large concentration of cases, and that's been about 4,000. So I'm going to show you a few graphs here. I think that the message overall, I can at least say, is that things have gotten much better for a lot of reasons, which we'll get into. But we did see cases peak in the summer and early fall, and now cases have come much down or come a lot lower. So this is a graph from the World Health Organization, which is basically an international type of organization similar to the CDC that we have here in the US. And this shows the rise of cases across all of these countries that are color-coded. So you can see Europe and the Americas have the bulk of the cases that are being reported that appear through May. They slope up, and late summer, early fall was where we saw the most concentration of cases, and they have been coming down. The reasons that are speculated to have caused this downtrend are, first of all, awareness. People are aware of what causes it. They're doing things to prevent. They're reducing their number of intimacy partners. And also the vaccine is much more available than it was before. It's not perfect. We know we still don't have, I think, the supply that we would want for anyone to get vaccinated, but it is much better and it's much easier to access. And those two factors have really helped. So the US has seen a similar downtrend, thankfully. So we've also seen cases start in May, peak in late summer, early fall. And you can see it brings us up to, gosh, I think that's yesterday, where our numbers are much lower. So who's getting infected with monkeypox? So a graph on the left from the CDC, it's going to show you the breakdown of ethnicity amongst everyone who's reporting infections or was diagnosed. So you can see the bulk of the population are Black or African American, Hispanic, and or white individuals. And then of course there's smaller denominations within that. The main age group that is having cases reported are middle age to older age, but mostly the concentration is around the 30s. That's the highest concentration. Men make up the large majority of this group. And like I mentioned, those who are most at risk because of where this infection has spread and stayed and circulated is among that MSM community. But again, anyone can be infected if you have the right risk factors or exposures. So we have seen cases in women or other transgender or other identifications. So why is this happening now? Why has monkeypox never done this before? Why have we not had cases outside of Africa? Why are we seeing spread this fast? And there's a lot of things that come into play. So I think it's important to know that cases of monkeypox were on the rise for many years. And I think a lot of countries in Africa and groups that work in Africa have been trying to sound the alarm bells. But when it comes to infection prevention, I think that each country tends to see itself as sometimes a bubble. And the problem is that a lot of infections, especially with travel today, they don't have those same borders they used to have 100 years ago. Someone can hop on a plane and bring something back, and before you know it, things can spread. So a lot of these alarm bells that were being sounded by these cases that were being seen in Africa on the rise, growing, more infectious, more transmissible between groups of people, probably weren't really heeded. So I think that eventually that rise in cases naturally spread, and this has to do with the advent of international travel. Like I said, you can hop on a plane. A lot of festivals after the pandemic has calmed down a little bit, where there's a lot more gatherings than before across many countries. There's also the concern that maybe this virus had some small mutations that allowed it to be more infectious or to be more contagious. And a lot of these animals that once lived far away from any homes or cities, as deforestation, as climate change changes our environment and where we live, the border between where humans live and animals live has become very blurred in a lot of areas. So now we're intermingling. And if we're intermingling, that means things that they carry and we carry can also intermingle. So what does monkeypox cause? So it can cause a lot of symptoms. But the goal with this graph isn't to make anyone nervous and say, oh, I have a headache, maybe I have this. Really, the hallmark of this infection is going to be skin lesions or a rash. That is the main hallmark. And I'd say upwards of 98% of people are going to have that. And if they don't have that, it's because they probably have lesions that are hidden somewhere or pain related to those lesions that they can't really see. They can't see those lesions. So that's the main hallmark. And we're going to go into some photos in a little bit. I just want to mention that there are some photos of things like genitalia with lesions. So if you have anyone's small children or anyone who doesn't want to see that, just a heads up. So starting from top to bottom, on the left, we have general symptoms. So monkeypox can cause the typical flu-like illness symptoms. So you can have your muscle aches, fever, chills, fatigue. It can cause throat and mouth pain because of oral lesions. The lesions can also appear in the genitalia, which includes the vaginal area, the penile area, or the rectal area. Pain associated with that, discharge associated with that, issues with bowel movements, issues with urination because of that. Swollen lymph nodes can also be seen, so maybe close to where you have lesions, so the inguinal area, also the throat. In some cases, you can have lesions in the eye. That's a little bit more rare, but that can happen. And sometimes you can have headaches and things like that. So this is a breakdown of the symptoms that have been reported with monkeypox infections. And like I said, upwards of 98% of patients are going to have that rash. And then a lot of those general symptoms we talked about, swollen glands, things like that. Halfway down, you'll see the list. You'll see rectal pain on the list. So this is going to be associated to inflammation of that rectal area, most often due to lesions. And those are some of the situations where someone can have lesions, but they're internal and they can't see them. So what do skin lesions look like? So these are going to be a couple photos in the next few slides. So starting from left to right, you're going to have a male patient who has small lesions on their shoulder. That's another unique thing we're seeing about this infection. In cases that were classically seen in Africa, you would see people covered in lesions, covered in skin infection. And this outbreak, since it's being transmitted mostly through intimacy in this MSM community and some outward communities, but concentrated there, a lot of it is going to be genitalia lesions, with a few lesions that can spread outside of the body or the face, things like that. So in photos A, B, and C, you have genitalia lesions that are kind of in different stages. You can see kind of a demarcated circle. That picture B has an umbilicated center, so it looks kind of like a little ring. And C and D have some small finger lesions. Specifically, D is kind of that classic lesion that we see that's a little kind of like a small pustule. You'll see that again on this next photo on the left side, that hand small pustule. But there's also different rashes that can appear, different types of skin rash. So whenever I refer to the manifestations of skin in this infection, I really like to say skin lesions or skin rash, because they can be either one, and sometimes they can both merge. So on the right-hand side, you're going to see this kind of lacy, red, bumpy rash, and that can look like acne. It can look like a drug allergy, things like that. So you can see that on the chest, the buttocks as well. So most of these skin lesions, they follow a pattern. So they go from a small flat red area, they become more prominent, they get filled with liquid, then pus, and then over time they scab. This next photo is a compilation that a patient himself put together of the progression of these lesions over the course of about 3 weeks. So you can see these lesions, they can look, really significant. You can see halfway the large amount of scabs. So scarring is a big concern. And in cases where the lesions are very prominent, it's very possible. So common things are still going to be common, if there's no presence of rash or lesions that develop within a matter of days of someone developing other symptoms like flu-like illness, muscle aches, headache. Again, unless you have really, really big risk factors, without that rash or those skin lesions that appear, it's most likely you're going to have something else. COVID, the flu. If you do have those rash or lesions, there's so many other things that can cause it. Anything from a herpes outbreak to chickenpox to shingles to infections we can pick up from kids like hand, foot, and mouth disease. The way we test for monkeypox these days is we just swab their lesions. Things are a lot easier now, so most labs can process this. We usually send at least 2 swabs of 1 lesion each to increase how sensitive that test is. And here, at least in the hospital, we get those test results within a day or 2. We are seeing a lot of infections with sexually transmitted infections. So monkeypox and HIV or herpes or syphilis, we're seeing a lot of those together. So if someone thinks they should be tested for monkeypox, they should also be getting tested for those other things if they have risk factors. So I mentioned this a few times before, but just kind of to hone it in. If someone has symptoms but no rash, there's no testing that's recommended at this time because the testing that we do is of those skin lesions. So if you don't have those, there's not really an area that we can really go after. Rash should appear within a few days after those symptoms. And there's a few exceptions where you may have, very specific rectal pain or urinary pain, where you may need a more thorough examination to look for those lesions. So this is probably the biggest question I get. How does this spread? So by far, the main way this infection is going to spread is going to be skin-to-skin contact. So it's mostly going to be individuals that are in close quarters, that are intimate. So this is, romantic partners. There's been some situations where it's roommates, where they're, in a small apartment in the city, they're sharing a lot of utensils and towels and things like that. Maybe they're sitting on the couch together. Body fluids to mucous membranes. So if someone has lesions and there's some kind of intimacy where your mouth is close to that, or some fluid from their own body gets in your eyes, that's one of the ways. For contaminated materials is what I was talking about in close quarters. So if you're sitting on the couch with someone and they have lesions, that have discharge or purulence, and that gets onto the sofa, or you're sharing towels, or, you're handling their bandages if they have wounds, that's another way. And then respiratory secretions, it's less common, but it can happen. In these cases, it's going to be prolonged time. So you should be around this person for a long amount of time. So someone who you're intimate with, you live with. In a rare situation, I saw a coworker, but again, it was a very close quarters and they were with each other day in and day out without mask use. So the main way is going to be through direct contact. A common question I get is, am I going to pick this up on the subway? Am I going to pick this up on the train? Am I going to pick this up in the gym? I don't think so. Is it possible? Sure. But the probability that you're going to pick this up from a public place is so unlikely. If this was the case, and there was this virus that was on public spaces, we would have seen this infection spread into all types of, individuals, not just mostly the MSM community. We would see, people of all age, children, women, men, of any identity. And we're not seeing that. So it tells us that it's really through close contact, very close quarters, that transmission is mostly seen. So is monkeypox a sexually transmitted disease? So I think there's a lot of opinions on this. I'm a little split. Can it be transmitted through intimacy or intercourse? 100%, absolutely. And that may be through direct contact, skin to skin, or it may be through exchange of body fluids, like semen and things like that. But it can also be spread through other ways. Just like I said, if you're on the couch with someone who has lesions and then you sit on that couch and it's soiled with that virus, that's one way you can get it. If you have a child and you're infected and you're preparing their food or you're wiping their face, you're touching their mouth, that virus can get into their mucous membranes, their eyes, their nose. And that's a way that it can be you can infect someone else, unknowingly as well. So it can be spread during intimacy. That's the most common way it's spread, but it can be spread many other ways as well. Anyone can get monkeypox, but really the most important thing to be aware is if you have risk factors. So for sure, that's going to be someone who you are intimate with or live in very close quarters with, who've recently had lesions that are suspicious for monkeypox, recently had a diagnosis of monkeypox, or if you yourself have multiple intimacy partners, especially if they're anonymous, you don't know their history, you don't know if they have any symptoms, specifically or if they're from that MSM community as well. So if you do suspect you have monkeypox or you know someone, you should absolutely get tested. In those cases, I would ideal to maybe phone your primary care doctor, phone the urgent care, phone the ED that you want to go into, just so they're aware when you come in that they should take precautions. So as soon as you suspect or someone suspects you have isolation in monkeypox or diagnoses you should isolate at home. So if you live alone, there's not really a lot you have to do. But if you live with others, then you want to take precaution that you don't put them at risk. So you can disinfect your surfaces in your hands routinely. There's nothing aggressive that you have to do, just routine cleaners. Your normal Clorox wipes are gonna kill this virus. You don't have to, worry about using bleach and things like that. If you are going to be using shared furniture, if you can put something down that you can pick up when you're done and wash it, that's always better. Manage your wounds yourself if you can. avoid sharing linens, towels, sheets, utensils that are unwashed. Once they're washed, that should be fine. And then, of course, try to separate if you can with food, eating. You should mask when you're at home, and you should cover your lesions if possible. And then we also have seen cases where pets have become infected from their owners. So if the animal around you, if you haven't had close contact with them leading up to illness, you should have someone else take care of them. But if they were very close to you, if you sleep with your animals, if you're constantly very close to them, they may have to quarantine with you just to make sure that they don't become ill themselves and infect someone else. So the majority of individuals are going to do okay with just symptomatic treatment, which means managing their pain. That doesn't mean it's not severe. Some people can have really, really awful pain. You can have scars from these lesions. You can have strictures and areas from these lesions. So it's very serious. But usually supporting those symptoms and trying to, decrease their severity is enough for most people to recover well. So you can use medications that are over the counter for rectal pain, oral lesions, anti-itch medications, and sometimes individuals do need prescription medication for pain. There is an antiviral that's being used, and it's called tecovirimat, and you can get this two ways. It's going to be through clinical trial, and there's a big clinical trial going on now, and that should be the first way that people get the medication. Or there's another way that you can get it through the CDC with the help of a doctor. So it's not FDA approved. You still need to provide informed consent. But the good thing is it can be given IV or oral. So we've given this to many patients and they can take it at home. So how long does monkeypox last? So the lesions can last an average of 2 to 4 weeks, but that picture we saw, that kind of running course of that male patient, he was at 4 weeks and he still had, you could still see the lesion. So it can take many weeks. It can take probably even a few months for these lesions to disappear completely, and you can have scars. And like I said, the pain can go from anywhere from mild and it can become severe. Now, if you believe you're exposed to this infection, the first thing to figure out, and this a provider can help you figure out, is if it was a very high-risk exposure or it wasn't. Now, higher risk exposures are going to be, if you were intimate with someone who was recently diagnosed, or if you were living with someone in close quarters who was recently infected or diagnosed, etc. The treatment for that, or the best prevention for that, is to get the vaccine, which I'll mention in a second. The vaccine, ideally, within 4 days is best, but the city does give it to you if you were exposed, I believe, within 14 days. And in some very, very minor cases, if you're not a candidate for the vaccine, so if you have, very little immune system because you're immunosuppressed from a condition, or you have a severe allergy to one of the ingredients, then you may qualify with approval of the State Department of Health or the City Department of Health for that antiviral we mentioned. If you're not higher risk, things like, oh, I walked into the room, and someone had monkeypox, but I didn't touch them. I wasn't there for very long. Or I touched their skin briefly, but I didn't have any open wounds on my hands, or I had a glove on, things like that. Those would be more low risk. And in those cases, we would monitor someone for symptoms for 21 days. That's the longest period of time someone should be able to be infected with monkeypox. And in the meantime, as long as you don't have any symptoms, you do not have to isolate. You can go about your life. Now that the vaccine is much more available, it's a lot easier for people who are exposed, or even if they think they were exposed and it wasn't very high, it's much more readily available to get the vaccine. So the vaccine that we're mostly using, there's 2 main vaccines, but JYNNEOS is by far the most used and the safest for this kind of situation. It's approved by the FDA for both smallpox and monkeypox, and anyone who's 18 years or older. And it is approved, or it has an emergency use authorization for younger patients in this current outbreak of monkeypox. So it's attenuated live non-replicating vaccine, non-replicating smallpox and monkeypox virus. What that means is basically it's a very, very weakened virus that cannot replicate. So you cannot develop monkeypox from this vaccine. It's the only function it has is to prepare your body to make antibodies against these viruses, but it cannot cause monkeypox or smallpox in that case. The data we have is we're still accumulating this data for this current outbreak. but the efficacy is suspected to be around 80% in preventing infection, which is very, very high. So they recently expanded the availability of the vaccine in New York City, which is great. So now anyone, any sexual orientation or gender, if you have multiple partners or anonymous partners, you're eligible to get the vaccine. You can sign up on the website, which I'll show in a second. If they have any intimacy partners or sex partners who meet the criteria above, as in their partners have multiple partners, that's also a qualification. Anyone who suspects they've been exposed also qualifies, and anyone just who thinks they're at risk. So before it was very strict, but now that there's more supply, it's become a lot easier. Who should get vaccinated now? So like we said, anyone from the MSM community or transgender community or non-binary individuals should get this. They're going to be the ones most at risk, even if they're not having intimacy with partners. The fact that a lot of people in their community could become infected and they could share, close space or social interactions with those individuals puts them at higher risk, especially if someone in this community has had a sexually transmitted infection in the past 6 months. Any woman who was born as a female, no matter how they identify, if they have partners who are MSM, they should also be getting vaccinated. And then anyone who's going to go to parties, festivals, where there's going to be a lot of prolonged face-to-face contact, skin-to-skin contact, sharing the same air for long periods of time with short distances to other individuals, should consider getting vaccinated. Anyone who is HIV positive, anyone who's taking prevention for HIV, and anyone who, is a sex worker or, has transactional sex for survival, housing, goods, they should also consider getting vaccinated. So this is the information for the website. You can essentially Google New York City, Jynneos or monkeypox vaccine, and there's a number you can call. The vaccine is 2 doses, 4 weeks apart, and we try to remind everyone that you don't have full protection until you get that second dose and have about 2 weeks, but even just the 1 dose has shown some protection. Now, recently we've started doing the intradermal vaccination. This has allowed us to spread the vaccine for a lot more people, and it's been shown to be just as effective as the prior subcutaneous vaccine. But anyone who is at risk of getting keloid scars, so this means our Black and brown community, Hispanic individuals, if you have a history of keloid scars, you should request the sub-Q because the intradermal does put you at risk for scarring worse than normal. And if someone is infected, they should come out of isolation once all of their lesions have scabbed and fallen off and you have new skin formation. And a lot of the prevention is, things we've mentioned, limiting your partners, asking your partners about symptoms, trying to use barrier protection during intercourse, though we know that if it's skin to skin, that may not be fully protective. And avoid sharing towels, linens, things like that if you have symptoms or you think anyone else could have symptoms where you live or your partners. There's a lot of information we still don't know. So if you do get infected, we don't know how long you're protected. We don't know how long you're protected after the vaccine. A lot of individuals have asked me if I got the smallpox vaccine, when I was a kid, do I still have protection? The smallpox vaccine should give you protection for up to about 10 years. And some people, vaccines last for a lot longer. But if we're this far out, I think it's low probability it's going to protect you fully. So if you are at risk, you should be getting the monkeypox vaccine. We still need to get more information about how effective that antiviral ticagrelor is. And our clinical trial that's pending will give us more information about that. And then we still don't know if anyone can transmit this infection if they don't have symptoms or if they don't know that they're infected, or when it's safe to have intimacy after infection. So I'm going to jump right along to polio. I'm going to talk a little bit more brief about this. There's a little bit less to say, which is a good thing. So polio. So polio is another virus, but polio is an RNA viral infection. Now, I like to make differences between RNA and DNA because the RNA viruses tend to mutate a little bit more. So COVID, for example, is another RNA virus. So the main thing that makes polio stand out from other infections is that it can cause paralysis. It can cause paralysis in the arms, legs, or both. And there haven't been any reported cases of naturally found or wild type polio since 1979 in the US. Now, those of you if anyone's older with us or has, grandparents that lived through those times, they may remember that this polio really peaked in the mid 1900s. So around, 1950s, 60s, 70s, that's when it was at its peak. And around this time, it caused 500,000 deaths each year. By the 80s, over 100 countries had endemic polio, which means there was ongoing transmission of this infection. And it wasn't until the World Health Organization, the WHO, they enacted a very strong polio eradication program in the late 80s that was extremely, extremely effective with vaccination. So in the majority of individuals, polio does not have any symptoms, which means you can have the infection, you will have no symptoms, and you can transmit the infection to others. Now, 1 in 4 people will have flu-like illness. So your cold, your body aches, your runny nose. 1 in 25 will get meningitis, which means you have swelling or infection of the fluid and the membranes around your spine and brain. And that can have high fevers, confusion, disorientation, things like that. And then 1 in 200 will have paralysis. Symptoms will start about within a week after you're exposed to someone if you do have symptoms, but the paralysis can happen up to 3 weeks after exposure. So the damage polio can cause is nerve damage, which causes permanent paralysis. So we have on the right these photos. The bottom picture is a photo, I believe it's of a pediatric ward. So like I said, the extremes of age are usually those who are affected most by infection. So you have your children, you have your elderly, and of course anyone whose immune system is weak. So you have this entire ward of these iron lungs, which are really, really common around the 50s and 60s, where basically the muscles that are responsible for breathing, like the diaphragm, they become paralyzed and they can't work, which means people have respiratory failure. So these machines basically force your lungs to expand. They do the work of what that muscle should do. And some people survived many, many years with this. And the photo on top is an older gentleman who had polio when he was younger and had an iron lung in his home and would spend, a few hours each day in it. So why are we talking about polio after there was such an effective campaign and, there was no new cases since the 79? Because there was recently a case that was diagnosed here in New York. So there was a case of paralytic polio in Rockland County in July of this year in New York. So the individual was an unvaccinated, previously healthy young adult patient. After that, there was a lot of water sampling that was done. So that's something we do with infections. Sometimes when we find something we're not expecting, or just for monitoring purposes, we'll sample the water. If you can find things in the water, it means people have it in their system and it's going into the wastewater. And since that case was found, there have been positive water samples for polio in many counties around New York, including New York City. So because of this, US reappeared on a list of countries where circulating polio virus was found. And this was, we were replaced on this list since the first time since that last case in 79. So that's a really big deal. Other countries on that list are places like Afghanistan and Pakistan, so it's since we're a very developed country with, a very modern health system, it's a very big deal. So just to take a snapshot of what's going around, a lot of the issues that we're seeing are vaccination. Vaccination has gone down and we're seeing a lot of vaccine hesitancy with parents and their children. So for example, in one of the counties in New York, only 2-year-olds, only about 37% of them were up to date with their polio vaccination. So this number should ideally be 100% because we want to make sure that polio does not return. So less than half of children this age were up to date with their polio vaccinations. And we've seen this pattern in a lot of groups. Sometimes we'll see it in groups of individuals that are religious and don't believe in vaccines, but we've also seen the vaccine hesitancy movement, in other groups, affluent individuals or people who follow vegan diet. So it's spread out. There's no one group of individuals we can say doesn't believe in vaccines. There's been a lot of vaccine hesitancy. And what that means is that these infections that have been eradicated and are part of the past can start to come back. So how does polio spread? So polio spreads through the fecal oral route, which means we are infected, we secrete it through our bowel movements. So if you go to the bathroom, you don't wash your hands, and you are carrying polio, you handle someone else's food, you touch their face, you touch your own face, and you can infect them. It can also be transmitted through saliva and respiratory droplets, like any other cold. And you can spread the virus before you even have symptoms and up to 2 weeks after your symptoms start. And even if you don't have symptoms, you can still spread it, so you may not know. You can get polio at any age if you are not vaccinated. So what is the takeaway message from talking about this is really, what can you do to prevent polio? There is no treatment for polio. There's only supportive care. So things like breathing machines, other things that can help support that paralysis if the polio were to progress to that stage. Since there's no treatment, prevention is the most important part. Now, the good thing is that if you were born and raised in the US, you can assume that you were vaccinated, unless you have specific reason to believe you weren't. So if you know, for example, you lived in maybe an area outside of the city, or you know for a fact that your parents didn't want to vaccinate you, or you yourself didn't get vaccinated for whatever reason, if you weren't born in the US, if those things did not happen, you can assume that you're vaccinated. Similarly, if you had your children follow up with their pediatrician and get all their routine vaccinations, they should have gotten polio. And the school records, they have to make sure that your children are up to date. There's few exceptions to those rules, but the standard typical schools will require that. So to prevent this, if you're not vaccinated for any of those reasons, you weren't born in the US, you weren't raised in the US, or you know that for a fact that your parents didn't vaccinate you, definitely get vaccinated. If you have any children that aren't up to date, have them get up to date. If your community members aren't vaccinated, then encourage them to get vaccinated. The great thing about the vaccine is that it is extremely effective, extremely effective. If you have all 4 doses, you have about 99% protection, and that's pretty hard. You know, our COVID vaccines don't do that. So even 2 doses of the vaccine, which a child can have as soon as 4 months old, gives you 90% protection. So like I said, any child or adult that hasn't received the full series should get vaccinated. Anyone who has incomplete vaccination, you know, especially in any of these areas of New York that have tested positive in their water, which are many now. But like I said, most adults don't need to if you were born and raised here, unless you have a specific reason to assume. What this means, and this is a common question, do I need a booster? If I'm an adult and I was vaccinated or can't remember, do I need a booster? No. Like I said, unless you have a specific reason to believe you weren't vaccinated, you don't need a booster, and you should still be protected from your childhood vaccines. If you have any questions, of course, you can always talk to your doctor, and then there's a number to call from the New York City Department of Health for finding one, and children who are older than 4 years can get vaccinated at a New York City location. So there's 2 main types of polio vaccine. So there's the oral polio vaccine, which we used to give, you know, many decades ago, and is still given in many other countries outside of the US, but we only give, or we no longer give this one since 2000. So this has a weakened strain of virus. And the great thing is that this is still a very effective vaccine. The downside, and one of the reasons we don't use it, is that it can cause you to secrete the virus through your bowel movements. So it doesn't mean that you're going to get infected. It means that there's a very weakened strain of the virus that you will secrete through your bowel movements. Now, if everyone around you is vaccinated, it's not going to cause a problem. The problem arises when those individuals around you are not vaccinated, and even a very, very weak strain can start to cause problems. So the inactivated polio vaccine is the one that we use now. So it's a typical injection, subcutaneous injection vaccine. It's very safe. It's very effective, like we mentioned, and this protects both against the wild type, which we saw many decades ago, and the weakened strain that comes from that oral dose. This is the vaccine timetable, if you're curious, but if you're a child, you get 4 doses, and if you're getting the vaccine as an adult, it's only three doses. So the big question is, but didn't we get rid of polio? If everyone was vaccinated, or the majority of the population, why do we still have issues with polio? So part of the problem is that polio is not eradicated from the entire world. So there are countries that still have it. Moreover, the oral vaccine, because it caused that weakened strain to be secreted, and not everyone in every country or every population was vaccinated, it was able to infect some individuals who were not vaccinated and mutate. So that strain of virus has become a strain that has continued to spread through the community. So the wild type is the original infection, but also we have this vaccine-derived very weak strain that can cause problems in unvaccinated groups. And that's what we saw in this specific case. If someone around you or everyone around you is vaccinated, it's not going to cause a problem. But that's what we're seeing. So you have a vaccine that's effective, but the downside is it can cause some secretions of the virus. So like we said, there's no treatment for the symptoms of polio. There's really only supportive care. So prevention is really going to be key. And finally, I want to touch on herd immunity, because this is a topic I think it's a nice phrase that we like to toss around, but I don't know if we do a great job of explaining it. So just in case, herd immunity is basically when a large population of your community, also known as the herd, is protected or immune to a disease. So if we're looking at this photo, on the left, the red guy in the middle, he is unprotected. So let's say he or she, they have a transplanted organ and they're they have to have a lot of immunosuppression. So their immune system is extremely weak. Let's say they were born with an immune deficiency. So they have very little to no immune system, or they're on chemotherapy, or they have severe allergy, any number of reasons we can't give them the vaccine. They cannot be protected because they can't get the vaccine. So their chance of being safe or protected depends on their group around them. So that's why all the guys around them who are dark, if they're protected, this individual in the middle is protected. And that's what's called herd immunity. Your community or your herd protects you. Now, because these guys in the black or gray color, they cannot be infected, the virus really can't penetrate that community. They can't become infected. And because it won't circulate, that virus can't mutate. So it's safer for the entire community. But imagine if it was flipped. Imagine if the red guy was the only guy who was vaccinated and everyone around him was not vaccinated. Even if that vaccine is extremely effective, he's going to be attacked on all sides from someone who could potentially be a source of infection. And furthermore, if that virus is allowed to circulate in the population, it can jump from one person and mutate, jump to another person or another person and mutate. And the vaccine that person had from the very beginning that gave him that red color and protected him may no longer be effective. So that's what we say when we say the more people get vaccinated, the more effective the vaccine is. Because if everyone has some level of protection, it forms a shield. Virus can't penetrate, virus can't mutate. So the vaccine is better. And people who can't get vaccinated are also protected. So that's the reason we talk about herd immunity so much. So the last question I frequently get is, could polio come back? Absolutely. If we continue to see rates of vaccinations decline or not improve, and we're seeing this amount of virus circulating in the water, it's a very real possibility that we can see other cases of polio pop up. And I think we're all a little surprised that we have only heard of that one case. It's important to know that people can be infected, like we said, and have no symptoms. So there could be things going on in the community we haven't been able to catch yet. But it's a very real possibility, which again is the reason why prevention is so important. So that's all I have for you all today. I'm happy to answer any questions if anyone has anything or try to clarify in the last few minutes, and I'll stop sharing my screen.
Thank you so much, Dr. Torres. I think I see Larry's hand up, if you want to go ahead.
Yeah, just to emphasize an important point. You said repeatedly about finding it in the water. It's important to emphasize that's not the drinking water, it's the sewage surveillance.
Yes,
it's an enteric virus. It goes through the gut, so you will find it in the sewage because of the type of disease that it is. But it's not in the drinking water. It's not like you have to boil your tea 3 times over.
Exactly. That is in sewage. Yep. So that's the water that comes from your toilets, comes from your shower, because we secrete it from our intestines. we flush it down the toilet and it goes to the sewage waste. But yes, absolutely. It's not drinking water. It's not potable water. Nothing like
What
that.
I have not seen, I did a little work, I'm not a microbiologist, not an infectious disease guy, is a week by week display, a time series of surveillance data in the sewage. I know back in, I guess it's July, when they had the one guy up in Rockland County and they had sewage data there, but I don't know if the rate of sewage observations are going up or down. There's a reason for the question, but that's topic A. Topic B is this. When you look at the vaccination data, as you displayed, and state-wise, it's way in the 90s. But if you do it by zip code, within the city of New York alone, you have areas that go down to 50% in the Bronx specifically. When I looked at the range of zip code data, it does go down to 50%. The children, that's the pediatric data. We have no idea about adults. And your point was, if you're born in the United States, the likelihood is you've been vaccinated. But if you weren't a child in the United States, if you're a kid someplace else, depending on where you were, the rate of unvaccinated is problematic. I don't know that anybody has good data on it. So if you have a 50%, going back to that wonderful illo about herd immunity, the two of them, the red, the black, the red. If you have a community with less than 50% coverage and a significant percentage at that, and surveillance data indicates there's a risk, that's why I'm wondering, sorry, that we've only seen the one case. It's like the dog that didn't bark in the night. Calm me down. Tell me that I know it's only 1 in 100 and I shouldn't be all at Twitter. I'm working on this. I'm on a vaccine hesitancy task force up at a Montefiore, among a whole bunch of other things. And we are looking at it, and everybody basically is at the watchful waiting. Can you add anything to my confusion and consternation?
I can add, but I don't know if it's going to be too reassuring. I think
I don't know is an honest answer. You don't know, you don't know.
I think we're all surprised that this one case is what we've seen. I mean, I think it's not, since like we said, it's 1 in 200 that we're seeing the paralysis. It's not too surprising that we haven't seen any new paralysis cases, but we are testing patients who have these respiratory symptoms to see if they have enterovirus that's consistent with polio. And we haven't found any recently, at least in our community. I think we're all a little surprised. And I don't want to be pessimistic, but I wonder if there's things going on in the community that we're just not finding because it's a cold-like illness. Someone doesn't have any symptoms. But if we're seeing that in the sewage water, it's a reflection of what's going on in the population, whether we're seeing it bubble to the surface or not.
So watchful waiting really is the right answer at the moment. The fact that it's only 1 in 100 with paralysis is not surprising. We're not getting more at the moment. And the one thing you didn't actually say it this way, but it's true about polio, it's true about monkeypox, that the COVID protocols, distance, hand washing, even the masks, generally is good advice against all of these, especially now as it's getting colder. We're expecting flu to go up. And the one thing you didn't discuss was this wackadoodle. I've only seen a couple of write-ups on it, where the genetics of RSV and the genetics of flu are commingling. We're getting a hybrid. And again, the mask and all the rest of it, it's a good idea.
I can't comment too much on that because I know it's the kids that we're seeing that mostly in, but I can reiterate that yes, that our recent numbers of respiratory syncytial virus in kids the lines are usually like this and our lines are like this. So I think that there's been probably a change in a lot of things lately, and we are seeing a lot of co-infections in children. Why specifically, I don't know enough about it to comment, but yes, in general, I think it's hard for people to sustain like this mask use and this social distancing forever because we just get tired of it. Like even us as physicians, we get burnt out by it. But the truth is that all these things are beneficial for any infection. You know, the mask use, the distancing, the hand washing. It's not that we have to go overboard and, you know, scrub our skin until we have, you know, dermatitis or inflammation, but I think in general, it's good advice, especially as the winter comes, COVID cases rise, which is what we're going to see. And we're starting to see already.
I feel like a cranky old man in the sea and getting invitations to Thanksgiving up in Boston. And the thought of going into Penn Station and sitting in an Amtrak train for 4 hours, much more than the family itself. They're all vaccinated, but I'm 73. I have high blood pressure. I'm a little overweight. And I'm saying, is this the time to not worry? And I'm saying, I'm a cranky old man. I'm worried. Again, can you calm me down and tell me just to chill?
I think that, I mean, it's all about what's the riskiest thing for you. You know, I can tell someone stay at home and you'll be safe, probably. But I think people want to, you know, live their lives and spend time with their family. I think that if you wear an N95, that's going to be a lot more protective for you. If you're boosted, that's a lot more protective for you. And if you avoid any crowds that are unnecessary except to travel, those all decrease your risk. And then the good thing about, you know, things like COVID now is that we have Paxlovid, which is, you know, a drug that we didn't have, you know, a year or two ago. So there's things that can decrease your risk. And even if you do find yourself in a situation where you're infected, we have more options. And thankfully, on top of that, Omicron is a little bit weaker than when we saw with Delta. So those things are all in our favor, but you know, it can still be a bad infection, especially with RSV and flu and all these things going on.
Thank you. I think we're running pretty short on time, but I just see one more question in the chat that I think is worth answering. Jeff just asked, if you don't engage in any risky activities, is it still worth it to get a monkeypox vaccine in case?
That's a good question. I think it depends on what I think you perceive as what your risk is. I think that's a fair statement. If you don't have, you know, any close interactions with anyone who's from the transgender or MSM community, or if you're not, you know, active with, you know, sexually active or having intimacy with anyone, I think you're very low risk. I don't really think that you qualify at this time, because the people who do qualify have to have anonymous partners, multiple partners, recent exposure. So I don't think you qualify. There may be a period down the line when we have so much more available vaccine that it could be open to anyone. If you are working in healthcare, if you're, say, a nurse, or you work in a nursing home, or, you know, in an area where you're dealing with a lot of people in close contact, maybe down the line, once they open up those requirements, that may be a reason to vaccinate yourself, even if you're not having intimacy. But I think if you don't have any risk factors, the probability that you get infected is so low. Even if you were to qualify down the line, I wouldn't rush anyone to get it.
Thank you so much. I think we're a bit over time for today, so I'm gonna let everyone go. But thank you so much for joining us today, Dr. Torres, for all your insight on polio and monkeypox. Very appreciated.
Sure.
Yeah. Have a great day, everyone.
Thank you so much, guys. Have a great day.
Thank you.
Thank you. Great presentation, Doctor.
Thank you.